Good afternoon and welcome. I am Kit Pugliano, the Dean of UC San Diego's School of Biological Sciences, and I'm delighted that you've joined us today. I'd like to thank all of our partners and collaborators who make the Deep Look Public Speaker Series possible, including our Biological Sciences team, UCSD TV, the Research Communications Program, and especially today's speakers. We held our first deep look into the fascinating world of artificial intelligence last fall with fantastic speakers who presented several insightful views of the AI revolution and how it's being implemented in research and industry. In case you missed that event, you can find it on the UCSD TV website by searching for the Deep Look series. Since that event, AI has continued to explode across virtually every aspect of our lives, and because of that, we're extremely excited to bring you today's Deep Look that will examine how AI is being adopted in the vitally important health and medicine sectors. Today, we have four outstanding speakers who will provide us with their expertise and insights on AI's implementation inside operating rooms, critical care units, and in our homes, along with critical ethical and social implications that come with this rapidly evolving technology. Following the presentations, we welcome questions from you and our audience. Please feel free to submit your questions. We will answer as many as our time allows. I am delighted to introduce our first speaker, Christopher Longhurst, MD, who is Chief Medical Officer and Chief Digital Officer at UC San Diego Health and a UCSD Biological Sciences alum. Dr. Longhurst's unique role provides leadership to medical staff, ensuring that standards and protocols are in place to provide the highest quality of care to patients and ensuring continued innovation. Dr. Longhurst also serves as an Associate Dean at the School of Medicine, overseeing and aligning education and research missions within the clinical environment. He is also a faculty member in the Departments of Biomedical Informatics and Pediatrics at the School of Medicine, who maintains an active clinical practice while pursuing scholarship in care quality, patient safety, informatics, and healthcare artificial intelligence.
Hi there. Thank you for that kind introduction, and thank you for having me here today. As mentioned, I'm Dr. Christopher Longhurst. I serve as the Chief Medical Officer and Chief Digital Officer for UC San Diego Health. And the way that I describe these two roles sometimes is that as Chief Medical Officer, I have insights into all of the challenges across the health system. But as Chief Digital Officer, I have a really unique and evolving set of tools to help solve these long-standing challenges in new ways. And so I want to share some of that with you today. First of all, a little bit about UC San Diego Health, where I get to work. So we're a large organization with over 10,000 employees. We provide care to a large population in San Diego. And with our CEO, Patty Mason, we've really been delighted over the last several years that our quality continues to improve. In fact, just last year, super proud that we're ranked among the nation's top hospitals by U.S. News & World Report. And you can see that list there includes 4 other hospitals in California. But UC San Diego is the only safety net hospital of those 5 that serves all comers all the time. So we have a lot to be proud of. And even among those top hospitals, from a quality and safety standpoint, the best of those hospitals continues to have more than 400 patient safety events on an annual basis. What does that mean? That means on average, over 1 a day patient safety event happening in our hospital. And these patient safety issues are not new. In fact, an Institute of Medicine report back in 1999 suggested that 100,000 Americans die on an annual basis from medical errors. So how are we doing now 25 years later? Well, Dr. David Bates, who actually informed that original report 25 years ago, repeated his study recently. And last January is published that 1 in 4 patients who are hospitalized experience an adverse event. And 1 in 4 of those adverse events are preventable. So that's really our charge, is to figure out how can we bend the patient safety curve. And as you might be able to guess, I'm excited about AI as a tool to do that. In fact, I worked with some patient safety leaders across the country to describe how could we use artificial intelligence as a tool to change outcomes for patients so that your family, your friends, when they're hospitalized, have better outcomes than they might otherwise. So we reviewed the literature and we got together some experts and we found at least a dozen different ways that we could use AI to help change those outcomes, to reduce these events that are adverse patient safety events. Things like line infections that occur in the hospital, or breast imaging and cancer screening that occurs too late, or missed findings on chest x-rays. So let me give you an example of that chest x-ray in particular. Now, I'm going to take you back a little bit to the beginning of the pandemic, which for us here in San Diego was not in March when it was declared by the White House. It was actually in February, because on February 7th, we became one of the first sites in the country to receive a plane full of expatriates evacuated from Wuhan. And as you can see here on February 10th, that first patient tested positive for what was then called coronavirus. And that patient was hospitalized here at UC San Diego. In fact, we published about that patient because it was one of the first 5 COVID patients hospitalized in the country. Now, I remember setting up our command center and all the policies and processes, and at the time spending thousands or tens of thousands of person hours. I was thinking, is this going to be another SARS, much ado about nothing? And of course, that didn't turn out to be the case. But it was because of all this preparation that a month later, when the White House did declare the pandemic, I was sitting in a conference room with one of our radiologists, and Dr. Albert Schau had already developed a machine learning algorithm to identify COVID pneumonia from a set of chest x-rays he got from Wuhan. In fact, he'd already had a paper accepted about this algorithm because it was shown that it was a valid and safe approach to helping to identify COVID on a chest x-ray. And so something that would have otherwise taken 8 or 10 or 12 months to implement, we did in just 2 weeks. And so March 28th, which was a Friday, 2 weeks after the White House declaration, we went live with this across our health system. And I'll never forget the following Monday, April 1st, when I rounded the emergency department, I asked the ED attending, have you seen the color on the x-rays? And she said, yeah, I've seen that color. In fact, we had a patient brought in by ambulance from a nursing facility for possible heart failure exacerbation. And there was no sign of respiratory distress, but we saw the color on the x-ray. And even though our radiologist didn't mention it, we went ahead and got a COVID test. And I said, well, what did the COVID test show? She says, well, it was a couple of days ago. It takes 2 days to come back. And I was standing over her shoulder while we looked for that test result. Sure enough, it was positive. And that patient was followed by our outpatient service, was proactively hospitalized and diagnosed sooner than she would have otherwise been. And then she did very well, actually went home without needing critical care. But it was a great example of the AI helping us care for a patient better than we might have otherwise. Now, that being said, that's anecdata, not outcomes evidence. And so we went ahead and did a study. And over the course of the summer of 2020, we asked every single physician about every single patient they saw who received a chest x-ray in our emergency departments. And so along with Christian DeMeff and Morgan Carlisle and others, we found over 2,000 patients that were receiving chest x-rays. And in those patients, our physicians told us that they changed their clinical decision-making in 1 in 5 cases because of the artificial intelligence. And that was a huge finding, right? It was published very quickly as a peer-reviewed paper. But what was really interesting to me was just last year when a review article about all the artificial intelligence articles with COVID was published. So this is 2 years worth of COVID AI. And what these reviewers found was that in over 9,000 articles published, only 4 of them had clinical outcomes. In fact, only 2 of them were from the US. And that paper I just shared with you was one of those 2. And to me, that really identifies the big gap that we have of needing to identify clinical outcomes that are meaningful to patients, not just studying algorithms. And so another example I want to share with you is about sepsis prediction. And there's been a lot of research on this over the last 3 or 4 years. In fact, for those who don't know, sepsis is a bloodstream infection that on an annual basis kills 1/3 Americans. Now, this bloodstream infection is not always easy to diagnose. 85% of the time it develops at home, and it can mimic a lot of other conditions. And so it's not always diagnosed in a timely fashion when we can prevent worsening, exacerbations, or even death. And so I'm particularly proud of Dr. Gabe Wardy and Shamim Namadi, some faculty members here at UC San Diego, because not only did they construct a multimodal AI algorithm and implement it in our workflow, they did a lot of design and process engineering to ensure that the right people are alerted at the right time, that this algorithm is trustworthy. In fact, they taught it how to say, I don't know. So that just like a good clinician, it's not making predictions when it's overconfident, and that's generated more trust in this algorithm locally. What are their outcomes? Well, just a few months ago, we published an almost 20% reduction in mortality in our emergency departments. Now, this is only the second ever publication showing a mortality impact of an AI algorithm in sepsis. And again, there's been thousands of publications on AI algorithms in sepsis, but this one showed a mortality impact. And so that's why the editor of the Nature journal actually just published this editorial where they comment on the fact that UC San Diego Health was looking at outcomes that matter, meaningful outcomes that matter to our patients and their families. And they went through the fact that this isn't just about the algorithm, it's about the end users and the clinical context and the monitoring. They described what we did. And they concluded that despite the rapid growth of AI applications in healthcare, few models have progressed beyond retrospective development or validation. And that's what they call the AI chasm. And in fact, among the small percentage of these algorithms have actually been implemented, even fewer have demonstrated clinically meaningful benefits. And so that's really what our focus is in the Jacobs Center for Health Innovation. We're incredibly grateful to Joan and Erwin Jacobs for a generous donation that they made in 2023. And our mission in this center is innovation at scale with impact. This center actually sits inside the health system, not inside the medical school, because our goal is to solve health system problems, things like unidentified sepsis. How can we help make our health system and our medical center a safer place to receive care that's equitable, timely, and delivered to all patients regardless of ability to pay? And so this focus is really culminating with something that we're calling a mission control. We're building out this mission control now, and we envision this not only as a place where we can help manage patient flow across our hospitals, because we're a growing system to 3 and soon to be 4 hospitals, but also how we can help provide 24/7 monitoring for our patients at home. We already have over 5,000 patients that we remotely monitor for chronic diseases, but today those things are monitored Monday through Friday for outcomes that don't need to be acutely adjusted. We see a future when clinical grade wearables in partnership with the Jacobs School of Engineering will be worn by our patients in a way that allows us to proactively identify using AI algorithms to surface those patients who might be at high risk for a heart attack before they have chest pain. And so I'm really incredibly excited about this future. But as we implement AI, we have to do it in a trustworthy and respectful manner. And so that's one of the reasons that we adopted AI principles in a transparent manner almost 5 years ago. And big kudos to Dr. Amy Sittapati, who's been co-chairing this committee. Our AI principles are public. You can scan the QR code there to see them. And in fact, I got to participate in a White House process to really clarify health AI principles. And we're in the process of updating ours to reflect what they call the SAFE principles. Now, one example of putting these principles into practice is generative AI. Now, this really exciting tool allows us to use text data to develop decision support. In fact, when we looked at our electronic health record, only about 0.5% of the record is discrete data. The majority of the clinical data, when you exclude all the billing data and exclude all of our audit metadata, it's actually text. It's the text that our doctors and nurses and respiratory therapists and x-ray techs and others are entering in the electronic health record. So generative AI creates a huge opportunity, but of course we wanted to start with a low-risk area. And so one of those areas was incentivized in part by this great publication from Dr. John Ayers in the Qualcomm Institute. And what John did in collaboration with a team of folks was to look at 200 questions posted to doctors on a Reddit social media forum. And of course, he famously found that the chatbot could construct answers that appeared to be more empathetic and higher quality than the doctor's answers. Now, this was not a direct comparison. The doctors did not know that they were being measured on this. What they did was to retrospectively look at these physician answers. And I'll tell you, as one of the 7 reviewers, it was pretty obvious that the chatbot answers were the ones that were always 4 times longer. Right? The doctor would write 4 sentences and the chatbot would write 4 paragraphs because it could do that in a short amount of time. That's what I thought one of the key takeaways here was that this chatbot could be helpful, though not perfect, in a brief span of time. And so we partnered with our electronic health record vendor, along with a couple of other institutions, the first in the country to implement this. You can see what this looks like. Here's Dr. Millen's inbox. And imagine being a busy clinician seeing patients, and while you're seeing those patients in clinic, you're getting a message about a patient with asthma, or a patient has a question about their lab results, or their sore throat, or their coughing. And so with the ChatGPT integrated into workflow, we're able to generate a draft reply. Notice, though, that there's two buttons, start with draft or start blank reply. There's no button that says just send now, because one of our principles is to always keep a human in the loop. And so if a physician wants to send this, they have to first go in and edit it. Now, another important AI principle that we put into practice here was transparency, and we decided to be fully transparent with our patients that we were using this. So every message that is starting with a draft reply includes an addendum that says this message was automatically generated and edited by and your doctor's name. And we've gotten very positive feedback from our patients about this. In fact, some patients hesitate to message their clinicians because they're worried they're so busy, and they were happy to see that their clinicians now have an AI co-pilot helping them do some of this responses. We found that it, interestingly, didn't save time. In fact, it took about the same amount of time to read the patient message and draft a response versus reading a patient message, reading the chatbot response, and then editing it. But what it did do was reduce the cognitive burden, it empowered our patients, and it made our physicians happier. And interestingly, we also sent, on average, responses that were longer, suggesting, like the earlier study from Dr. Ayers, that they may be higher quality. So, really exciting time. Some of the key points I want you to take home. Number one is that health AI paradox, that implemented algorithms are rarely researched, and researched algorithms are rarely implemented. Number two, the Jacob Center for Health Innovation at UC San Diego is focused on closing that gap, because we're not only implementing AI algorithms, we're doing it with workflow and process reengineering to ensure that we're impacting patient care outcomes that matter to our patients and their families. And then number three, all of our AI efforts are reviewed by our governance to ensure that each algorithm is fair, appropriate, valid, effective, and safe. And so a lot going on in this space. I'm really excited to talk today and want to thank you again for having me on board.
Next, I'm very pleased to introduce Camille Nebeker, a professor of public health with appointments in the UC San Diego Herbert Wertheim School of Public Health and Human Longevity Science and the UC San Diego Design Lab. Dr. Nebeker is a research ethicist who directs the UC San Diego Research Ethics Program, a university-wide resource for research ethics education and consultation services. In her role as Director of Recode Health, her team conducts research to inform and shape ethical research practices in technology-supported health research, including digital health and AI. She also serves as a member of the World Health Organization's Digital Health Roster of Ethics and the IEEE Organizational Governance of AI Working Group. Dr. Nebeker's research has been supported by a variety of federal foundations, as well as the Patient-Centered Outcomes Research Institute and the Robert Wood Johnson Foundation.
Well, thank you so much for that kind introduction. I'm really looking forward to being here. And I'm going to dive right into my slides. Two of the roles that I have at UC San Diego are, one, directing the Research Center for Optimal Digital Ethics in Health. We call it Recode Health, which was launched about 5 years ago in the midst of just public attention about the problems with social media, concerns about digital health, different kinds of products that were being used in the health system. And we were fortunate to get a seed grant from UC San Diego to start this center, which focuses specifically on shaping responsible and ethical research practice in the emerging field of digital health and artificial intelligence. I also direct the UC San Diego Research Ethics Program, which again is focusing on ethical practices, but for the broader campus community. And this is a group of people, behind everything that we do at Recode Health and the Research Ethics Program, we are working with people trying to shape how we think about the research that we're doing, the integrity of the research and the scientific process. And so about 10 years ago, one of my colleagues in behavioral medicine wanted to do a study to observe people in the wild. And this was a precursor to precision medicine. And by understanding how people move through their day, she could identify whether or not they were sitting or standing or eating or socializing. And it was a really innovative study that was funded by the National Institutes of Health. Well, she went to get an approval from the Institutional Review Board, and they said, well, the study sounds great, but you can't use the tools that you're planning to use. And one of the tools that she wanted to use is the camera in the middle of this picture. It was a camera that was made by Microsoft, and it was used initially to help people who had dementia recall the day of their life. And so by losing memory, they couldn't remember things that they had been, where they had been, or people who they had spoken to. So they could use that camera for recall. Well, she wanted to use it to document what people did in their everyday life, how long they were shopping, when they were at a park. And so that was the minute that I understood this was going to be a really difficult era of digital health and artificial intelligence, because the IRB system, the institutional review board that we have, may not be up to speed to review the new kind of research that we're seeing. At the same time, we're looking at how can we use data that were never intended for health research. You know, things like environmental sensors, picking up air pollution, or social media. How do we use Twitter to track disease trends? Could we use, obviously, the electronic health record is one of the first tool or resources that we've used to apply artificial intelligence and predictive analytics. So all of these new tools, including wearable sensors, were just starting to emerge. And the Institutional Review Board wasn't certain about how to assess risk, what should be in the informed consent. And that's when we decided this is going to be an area of research that we're pursuing. And so for the past decade, we've been looking at these different kinds of technologies, the kind of data that they're producing, whether they're in a research record or whether they're in an electronic health record, who's got access to these data. It's really an important time to start shaping what we think of as ethical and responsible research practices. And just last month, an article came out in the LA Times talking about how the industry, everything to do with artificial intelligence, is moving so quickly that people in Washington, people in academic institutions, in industry are just really grappling with what's the best way to move forward and not overregulate, but not underregulate. And we've already seen how the data that are being used to inform these models could really cause harm, because it's really dependent on where the data in the data set have come from. Are they representative, or are they really geared to benefit people, white people versus people of color? And some of the studies that have been done recently have really shown that people of color are the most disadvantaged in this area because the data sets don't have enough people of color in them. And so how do we move forward ensuring that the data that we're using to build the AI models are inclusive of those who stand to benefit? How do we ensure diversity? And these are really important questions. And one of the areas that we're really focusing on is not only how do we get representative data, but to do that, you really have to change how research is conducted and how informed consent happens, and who is responsible across the lifespan of the data set build and use. And so these guardrails are something that my research team has really been focusing on. So we have funding to do research on informed consent, on risk assessment and management, as well as on return of information to people who are contributing to the data sets. How do you do that respectfully, and how do you do that in a way that results in meaningful data and not just information? And so we have received support from Patient-Centered Outcomes Research Institute, the National Institutes of Health, and the National Science Foundation to do this work. And one of the studies that we have been leading is the Bridge to Artificial Intelligence, which is a major initiative from the National Institutes of Health, and branded as being ethically sourced. So building ethically sourced data repositories. What does that mean? What does it look like? And that's part of what our ethics group is doing, is determining what data governance looks like. How do we collect data? What is the storage practices? how do we access, use, and reuse? And so informed consent is one area that we've been spending quite a bit of time on because it can't get worse because it's such a difficult process. If this is what you see when you're thinking about enrolling in a study, it's not going to be very helpful. And so it's a lot of words. We're relying on people to be research literate, technology literate, and data literate. And we have to take some steps back to think about what could we do to make it more accessible. Now, this, I'm not going to say is accessible. This is too much information. This is what is in the informed consent document that's been broken down into chunks. Now, those chunks aren't making it any more accessible, but now we can see what the pieces are. So could we take these pieces and work with people to find out how do we present this information in a way that's more accessible to you, that you have access to what you need to make decisions about choosing to contribute to a data repository or participate in a digital health research study. And we do this process called human-centered design, where we work with people. We ask them, what do you like about this? What would it look like if it was designed for you? And then we build prototypes and we listen to what they're saying, and they tell us if they want to see a video, or if they want to be able to make the text get bigger or smaller, if they want to choose what part of the consent they go to first. All of these things are intended to be a process to get this to be more accessible. And so this is a paper that we published recently on exploring the future of informed consent. And, one of the things that I think our team is really excited about is not only making informed consent informed, but also helping researchers decide how they're going to do their research, what tools they're going to use, what wearable sensors, what partners, what vendors. And so we've created tools to help with that decision-making process. And these are available on our Recode Health website and are being used across globally, actually. And so data management, this is just one example of how our framework is being utilized. So it's anchored in ethical principles, a respect for persons, beneficence, justice, and respect for law and public interest. The checklist items are all embedded under each of those ethical domains. And in conclusion, I want to really stress that AI governance is critical, that it involves thinking through every aspect of the problem you're trying to solve, whether it's fit for the right purpose, where informed consent is happening, how data are being managed, thinking through risk assessment and mitigation, and the risk to benefit evaluation. And at UC San Diego, not only do we have the research ethics program working on this, but also a Recode Health team. I participate on the UCSD Health AI Committee, which is connected to our Center for Health Innovation. And also, I'm also involved in the UCOP, University of Office of the President, AI Council. So as a UC system, we're doing an awful lot of work to make sure we are creating the proper structures so that we can do AI research in health ethically and responsibly. Thank you so much for inviting me, and I look forward to the conversation.
And now I'd like to welcome Dr. Laurel Rick, a UC San Diego professor of computer science and engineering in the Jacobs School of Engineering, who also has appointments in the Department of Emergency Medicine, the Contextual Robotics Institute, and the Design Lab. Dr. Rick directs the Healthcare Robotics Lab and leads research into human-robot interactions, assistive and accessible technology, embodied AI, and health informatics. Dr. Rick's current research projects hold applications in acute care, neurorehabilitation, and home health, and focuses on furthering health equity through community health efforts. Dr. Rick has received the NSF Career Award, the AFOSR Young Investigator Award, the Qualcomm Research Award, and multiple Best Paper Awards. And she also leads the ONR Muri Huddle Project and has been supported by an impressive array of federal agencies, companies, and foundations.
Thank you very much for the introduction. So I direct the Healthcare Robotics Lab, and I focus on designing robots and embodied AI technologies that can support disabled people and their families. I also focus on technology that supports the clinical workforce, including clinicians, community healthcare workers, and professional caregivers. My lab takes a health equity and human-centered approach in all of our work, where we center the voices and ideas of people who are historically excluded from technology development to ensure that any technology we create is well aligned to their needs and reflective of their ideas. So the act of care work, supporting others and supporting oneself, is undervalued. People who engage in care work are overworked and underpaid, and many live below the poverty line, unable to make ends meet. What's worse is how invisible all of this work is. Care workers do so much to keep others afloat, yet they are often taken for granted. A recent paper by Joy Ming and colleagues draws attention to this invisibility and critically examines the role technology plays or fails to play in addressing this. They highlight the complex dynamics of the nature of care work and how adding technology risks exacerbating these social ills. Given this context, one big question is, why AI? Why robots? A lot of technologists will frame things around care gaps and how AI is going to solve all these problems, augment human care work, empower disabled people, etc. But ultimately, these sentiments fall flat when you start to ask the why questions. Why are there care gaps? Why is there a shortage of care workers? Why is their work being undervalued? Why do disabled people face so many barriers to access and care? And so on. Once you learn the answers to those questions, you start to realize that the problem is systemic and societal. We don't value disabled people and we don't value those who provide care work. So AI is basically a Band-Aid. It's not going to fix these major systemic and societal problems by itself. However, we are at an excellent inflection point to pause and reflect on how we develop and use AI and how to consider if, when, and how it can support caregivers and disabled people. When we connect the communities we want to work with and bring them into the research and development process, give them ownership of technology design, center their voices and ideas, we have a much better chance of getting to where we want to go. For many years, my students and I have been working closely with people with dementia and mild cognitive impairment, their care partners, and clinicians to envision the future of dementia care. We've been particularly motivated by questions of access. We explore how we can use technology to extend the reach of clinical and social services, and how we can design accessible and effective robot and AI-delivered health interventions. And we explore how to do this in a way that reflects the goals of our community partners. MCI and dementia affects about 50 million people worldwide and will affect 131 million people by 2050. MCI can affect a person's cognitive abilities, ranging from mild symptoms such as reduced concentration and challenges with prospective memory in the early stages, to the inability to engage in instrumental and functional activities of daily living in the later stages. People with MCI and dementia require personalized and unique interventions to support their health and independence. There's currently no cure or effective treatment for MCI and dementia, but there are behavioral and lifestyle interventions that can effectively slow the progression of the disease. And there are many things we can do to improve quality of life and support care partners in the later stages. We're developing robots to support people across the spectrum. We've been working with people with MCI and with clinicians to develop Carmen, a physically embodied robot that delivers practice-based and evidence-based intervention for MCI. We've also been working with people with advanced dementia and their care partners to design robots that can make life more fun and enjoyable. We can't cure anything and we're not trying to. Our aim is to provide enrichment and improve quality of life. Today, I'll be focusing on Carmen and MCI, but I'm happy to discuss our other work offline. The intervention we use on Carmen is CCT. It teaches people metacognitive strategies to help strengthen cognitive functioning and minimize the impact of impairment on their daily lives. For example, we might encourage someone to make a habit of placing their keys next to the door when they return home, or using strategies such as visual imagery to compensate for memory difficulties. We're adapting CCT to be delivered via physically embodied robots. The inspiration here is that robots can extend the reach of an intervention. This is a theme across a lot of our projects, where a robot can help with the homework between sessions with a clinician to help reinforce concepts at home. We hope one day we can extend this work to the point where the robot chiefly delivers the intervention to help expand its reach. Now you might say, why a robot? Why not an app? Well, one thing that we found both in our work as well as others in the field have found is that there's something really unique about a robot's physical embodiment that helps people engage with it when it delivers an intervention and sustain working with it, much more so than an app. So how do we translate an intervention, which we know works well in a clinical setting, onto a robot to be delivered at home? We know long-term interaction leads to better adherence and outcomes, But how do we do this for people with MCI who have unique requirements? For example, they might be easily frustrated or overly stimulated. We conducted some formative research to explore this in concert with our clinical collaborators and people with MCI. This yielded a number of helpful design considerations for design robots with people with MCI and design patterns for how to translate clinic-based interventions into the home. One of our most striking findings was how clinicians emphasize rewarding a person's perseverance over their performance, as they may not necessarily show improvement throughout an intervention. So here, a robot could reward users for behaviors such as maintaining a streak or trying out new strategies. It's also important to connect the intervention to the real world so that people can transfer what they learned into their everyday lives. Clinicians might ask people to reflect on opportunities where they can practice a cognitive strategy, such as remembering names at a social gathering or their grocery list. Robots could employ these approaches as well. It's also important to consider a person's interests in an intervention to make it more enjoyable. Robots could do this, for example, leveraging games or books that the person enjoys to make things more interesting. It's also important to help people set intervention goals to help them be more aware of its impacts. So clinicians work very closely with people to set achievable goals, and a robot could help facilitate this by asking users to reflect on their cognitive concerns and helping them to identify potential solutions. Finally, it's very important to make robots cognitively accessible to people with MCI by minimizing cognitive demand. This can be achieved by keeping intervention content simple and succinct and organizing information logically to help users maintain focus. Similarly, repeating information can help users review material, so it's important to reiterate important points and ask people if they'd like anything repeated. So we used all these findings to develop our robot Carmen, the cognitively assistive robot for motivation and neurorehabilitation. Carmen delivers compensatory cognitive training over time and autonomously to people with MCI at home. It gives people with MCI an opportunity to practice compensatory strategies via activities like remembering lists of words, like grocery lists, using a calendar, or engaging in note-taking. Carmen's based on the open source robot platform Flexi, which was developed by colleagues at the University of Washington. And we made a number of modifications to the hardware and wrote all the software from scratch. Basically, Carmen is using what's known as a content controller to give a person information on how it should behave while it's delivering that content. It then considers a person's responses via tablet and speech and adjusts its behavior accordingly. So for example, if a person performs an activity and doesn't do well, Carmen might give them encouragement, whereas it might celebrate if they do well. At the end of the day, the robot sends this interaction data that it collected to a database, and each night we have a machine learning system that can adjust Carmen's behavior to prepare for the next session. So I'll show you a brief demo of Carmen teaching one of the CCT strategies to a participant in their home.
The number one way to remember something is to write it down. Writing helps encode information in your brain. It can be helpful to have a notes section in your planner where you can quickly take notes throughout your day. Let's practice note-taking. We'll play the color game to practice note-taking.
Oh, right.
Great job. You remembered 5 colors when practicing note-taking.
So we ran a feasibility study first with clinicians and then with people with MCI. Each used the robot for 1 week and also completed a companion workbook, which the robot instructed them on how to use. We collected several measures, including questionnaires, usage data, and semi-structured interviews of participants' impressions, expectations, and experiences regarding Carmen. We learned a lot of interesting things, but I'll just briefly summarize them. Participants with MCI expressed their willingness to try strategies with Carmen that they previously wrote off as impossible. For example, after learning the overlearning strategy with the robot, participants described using it to help remember information for class. They also discussed using the note-taking strategy to remember names and using the mindfulness strategy to de-stress. This was particularly exciting given that our clinical participants expressed that even if people with MCI decided not to incorporate every strategy into their lives, learning and using a few new habits can lead to marked changes. Participants stated that they wanted Carmen to exhibit greater degrees of autonomy. For example, they envisioned the robot being more involved and providing greater support when they were completing their activities. This was really interesting and raises a lot of questions on how much autonomy we want the robot to have versus how much clinicians might want participants to do the work on their own. Our clinical participants discussed translating Karman to other populations. For example, maybe it could support children with ADHD, where the robot would complete activities with the child before the child could unlock screen time. The flexibility of Karman's system design enables extending its uses quite easily, so we're very excited about exploring this. In future work, we plan to explore using wearables and privacy-preserving IoT sensors to detect real-world strategy usage. For example, a user could aim to remember their keys when they leave the house, so Karman could provide them praise and encouragement and help them connect the dots between the intervention and the real world. So to wrap up, I discussed our collaborative work with people with MCI, care partners, and clinicians to develop future technologies like Karman that deliver clinic-based interventions for people with MCI in their homes. And our hope is that robots like Karman can extend the reach of interventions and improve the experience of MCI and dementia for all. I'd like to thank our community partners, my students, and our sponsors, and I'm happy to take your questions.
Our final speaker is another one of our proud biological sciences alums. Mark Schutzel, MD, MBA, is the Division Chief of the Department of Orthopedic Surgery with United Medical Doctors and is Chief Medical Officer at Motive Health. He began practicing medicine in 2009 and specializes in shoulder and elbow reconstructive surgery for patients of all ages. He uses leading-edge technology across clinical interests that include orthopedic procedures, such as arthroscopic rotator cuff and labral repairs, shoulder and elbow arthroplasty, and instability procedures, including Tommy John surgery. He also has an interest in health technology startups, having recently earned an MBA from the UC San Diego Rady School of Management. He is an emerging leader in the American Shoulder and Elbow Surgeons, the American Orthopedic Association Honor Society, and the American Academy of Orthopedic Surgery.
Thank you so much for that kind introduction. Today, I'll be discussing AI's role in healthcare from the perspective of how we can use AI to improve the patient experience as well as patient outcomes in surgery. And so since the start of the COVID pandemic, we've become acutely aware of brewing challenges in delivering quality healthcare that the pandemic has really caused to bubble to the surface. The most obvious of these is a great resignation of healthcare workers. And so what we're finding is we have a lack of trained and available staff as nurses, OR staff, and anesthesiologists are just becoming burned out and have been quitting. This has really increased our burden of care and has also decreased our ability to take care of patients. For me as an orthopedic surgeon, this is a huge issue because if I need to get a patient to the OR relatively quickly for something like fracture care, this becomes very difficult, in which case patients have to wait, and this slows the quality and timeliness of the care we can provide. And so patients now are also coming in more often for screening procedures like colonoscopies and mammograms, and we're seeing an increased care burden since COVID. People are really catching up on procedures that they weren't doing before and are returning for non-urgent care. And so these, for me, like total hips and total knee replacements are finally being put back on the schedule after years of delay as they were deemed as not as important or a priority versus other life-saving procedures. And also, we're having issues involving the current electronic health record. We have an increased requirement for documentation, and the EMRs are becoming very complex. And so there was a study recently showed that doctors spent on average about 67% of their day on using EMRs. And this was based on an NYU study from 2022 showing we're actually spending most of our day not taking care of patients, but mostly documenting about them, which is really not good for patient care. And then the last thing is about surgical technology. So we're really seeing big advances in robotic surgery. Some of you may have seen that the new Da Vinci Gen 5 robot just came out. One of these San Diego hospitals is going to be the first in the world to be using it. In orthopedic surgery, we're seeing 3D printing and augmented reality. But the problem is that us as a human factor are limiting our progress. There's only so much we can do for things like haptic control and safety in surgery. And so what this has really led to is an increased burnout amongst our healthcare workers, as well as decreased hospital practice efficiency. And then more important than this is mistakes and errors are made in medical care, which really ultimately hurts our patients. And then we're seeing a lack of progress with some advancing surgical technology due to us as barriers. And a recent Medscape study found that from last year, about 93% of physicians out of the 3,000 that were polled really admit to signs of burnout. And the most common sources of blame for burnout include the increased number of tasks that we now have to require to do, as well as increased patient load, and then woes with the EMR. And so the question is really, how can AI be used to address all these issues? And so I'd like to discuss 3 solutions and highlight a few companies that have really taken the lead in moving the ball forward in this. And so for solution number one, so we want to use AI to optimize hospital operations. And so the goal is to increase the number of beds that we can use in the hospital, number of surgeries we can perform, increase the throughput through the ER so we can see more patients in a given day, and then maximize the use of our staff, knowing that we don't have as many people working with us in the hospital, so we need to use the resources we have more efficiently. And so one of the ways that we've done this, there's a company called Juventus, and they use AI and machine learning to predict and control hospital flow. For me as a surgeon, this has been a really huge value add. What we allowed Juventus to do is to use the OR as a tool to increase optimization. So this product basically uses the OR, and then based on case type and surgeon habits can determine the flow. For example, it looks at the amount of time that I use in the time that's reserved to me, which is called block time. It tells me how much I'm using it effectively, tells me if I'm using it, and then it also allows the system to find white space or blank spaces where surgeries can be scheduled. And the other thing that it will do is allow it to address staffing needs. So where do you put your nurses? Where do you put your anesthesiologist? How many trays do you have for my total shoulder replacement? And then also takes the OR scheduling out of human hands. So when we're calling the hospital, faxing over an OR form, you can actually do it with 2 clicks of a button, which can be done by your own staff in your clinic to find, hey, where can you take these patients for the OR? For me, this has been huge. My staff, with 2 clicks of a button, can schedule my whole day instead of having to call on the phone, send a fax. And where I see the big difference has been is we've actually turned this product off at one of the hospitals that I work at in preparation for uploading to Epic and changing our medical record system. And it basically crashed and burned in terms of the operations of the hospital. We've gone back to the 1980s where we have to make phone calls again. Staff are frustrated, surgeons are frustrated, and our efficiency has really dropped. And what this is translated to is frustrated patients and frustrated surgeons. We can't take our patients to the OR in a timely fashion, and really efficiency has dropped by about 80% since the changeover. And the question is really, does it work? And so I think that use case where you see when you tried it and it worked great, and then you turn it off suddenly and you see the big difference, I think is a great case for showing that it has worked quite well. This product was actually first deployed at where I did my residency at St. Luke's of Kansas City. And looking at 1 year, they were able to actually increase almost to 1,000 extra cases added to the ORs in a given year, and then added a 36 extra bed capacity in a hospital. This project is also being used at Boston Medical Center, so they've been able to save over $3.2 million in excess savings and really save over 13 beds per day capacity created, which is huge for meaning we can take care of more patients in a timely manner. And so solution number 2 is looking at AI for documentation efficiency. And the goal of this is to reduce the time that we providers spent documenting and actually focusing on patient care. As you can see in the picture above, this is the worst type of provider, the one that's not even looking at the patient. And so when I instruct my medical students and residents and pre-meds, I really tell them, engage with your patient, look them in the eye. And in my practice, we document afterwards. What the downside of this is now I'm spending tons of time after clinic documenting, which means I'm not seeing my family. I'm not doing wellness things that I want to do in my life. And so really there has to be some sort of a balance where, hey, we doctors can reduce our after hours work because we have lives too, but also we can spend a lot of time focusing on actual patient care, patient engagement, and building that strong doctor-patient relationship. And so there's many companies that have been doing this. Companies like Freed AI and DeepScribe have really taken the ball and run with it about how to use documentation using AI to make it more efficient. And then even companies like Phreesia have gotten into the mix, focusing on scheduling efficiency. So taking the scheduling for your clinic out of the hands of a person and making it more of an AI-driven product. And so you can see lots of companies have come to the market. And so the question is really, does it work? So the top stats are about Augmetics. And so they've really saved their patients up to about, or their physicians up to about 3 hours per day in extra time spent in their life where they can otherwise be doing other things. So 3 hours bonus gain, as well as increases in both patient satisfaction from the patient side, as well as improvement in work-life satisfaction from the physician side. And then looking at Kairos at the bottom, they've been able to do over 3.5 million appointments scheduled in just a single year of product placement. So which means that they're taking all that work out of the hands of a medical assistant that can be now doing something else, maybe direct facing patient care. The two pictures on the right side are actually showing what the interfaces look like for some of the other companies. And so you basically dictate directly, or you have the phone on in the room with the dictation running, and it translates it right into a note. And it's interesting, I talked to some UCSD students last week who are working in the data science field, and they've actually created their own products like this. And they told me that it took them just a few days to do this. And I think that's huge that our own students will be able to make these products for us and really innovate. And so lastly, we're looking at AI to improve surgical outcomes. And so the goal of this is to reduce intraoperative complications and really improve our outcomes with minimally invasive techniques. And what we're going for here is surgical precision. And so there's lots of ways that AI has been doing this for us. Machine learning for intraoperative guidance is chief among these. And so we're basically, for orthopedic surgery, using predictive analytics for implant positioning. So where do I put the femoral component in my total knee arthroplasty? Where do I put the glenoid or the socket component on my reverse total shoulder replacement? How do I put it more accurately where there's the best bone stock and to reduce the risk of complications? And so the biggest benefit of this is actually a guide for medical training, as we can use the new technology to teach our trainees, medical students, residents, and fellows how to use their skills, and then surgeons some new tricks to be more effective and to really come along in terms of innovation. So lots of companies are doing this. Everybody knows about Intuitive and their famous Da Vinci robot, and then RSIP Vision and Argonne National Laboratories getting into the orthopedic space. And so does it work? So the first AI-assisted total knee and total hip replacement is scheduled for rollout in 2025. This uses the robot and machine learning to tell us where to make the cuts along the ends of the femur and the tibia for a more accurate total knee replacement that's not going to have loosening or something called gap balancing problems, meaning that the knee can become unstable because of where you made your cuts. And then the Da Vinci new robot actually has predictive haptics. So this will prevent surgical error. My own twin brother is a colorectal surgeon and actually is trialing it and said it is amazing. It actually predicts where your fingers can move to avoid any type of trauma or injury. So really pushing the ball forward. And so really AI is here. We are so excited that there are applications for AI improvement in patient care. We hope to do this by optimizing our practice operations, by reducing the burden of EHR documentation, and then by improving our precision in surgery. And so the goals of this are really to reduce physician burnout and medical errors, and then also to improve the quality of care that we can provide as physicians. So thank you so much for your time, and I'll throw it back to Dr. Poliano.
Thank you for just a really engaging conversation. And I thought I would start with a question about how you deal with explainability in the AI recommendations. Can patients and doctors easily understand the rationale behind the recommendations? And how is this transparency embedded in the platform or in the way that you enable and deploy AI in your workflow? So I guess I'll start with Dr. Longhurst.
I think the explainability of AI is a really important topic, and equally important is transparency, right? So we may not always understand the algorithms, but we know the data that was used to create those algorithms, and we know the output because we can monitor it. And so I think the transparency is really the key, rather than sort of the detailed explainability. So as I shared in my talk earlier, being transparent with our patients that we're using generative AI to help respond, but then keeping a human in the loop so that our clinicians are always editing and reviewing those messages before they go out. And being transparent about that is helping to explain that process. So hopefully that helps answer the question.
Fabulous. Thank you. Dr. Schultzel, would you like to add anything to that?
The biggest thing with AI, with patient care, is in explaining to your patients about how we're using the AI to really get a really complete medical record to allow them to receive the care that they need. Our biggest issue right now is documentation. We have to document so much. So if you need to go get an MRI for your shoulder, I have to document that you've completed 3 months of patient or physician-directed non-operative care before an insurance company will even agree to it. So during that conversation, I can talk to the patient and say, oh, you've done, Pilates and some gym activities for 3 months. It'll check the box. All that kind of gets in the discussion, and then we'll translate into less numbers of phone calls that we have to make, begging and fighting with the insurance companies to get the care we need for the patient. So it'll shorten the time that patients have before receiving care, increase their efficiency, and then allow us to spend more time with the patients. I can ante up to a patient and spend more time with them because I know, hey, I can spend less time documenting later because it'll be done for me.
Wonderful. Thank you. Dr. Nebeker, would you like to add anything to this from your perspective?
I think from a patient perspective, having some education about what artificial intelligence is, what machine learning is, what predictive analytics are, how those are generated, basic education is going to be so critical for really building a partnership with the patients. And how we go about capacity building, I think, is something that we need to start prioritizing, whether we put that in communications in the portal, but just little things that we can do, bite-sized chunks that allow the public to be more familiar with what data are. And I'm in my talk, I mentioned data literacy. That concept of data is just difficult. And especially when we start applying technology to data, it's just a mystery. And I think the more we can unpack that mystery and make it more accessible, and using examples of how it's used, when it's used, who's in the loop, as Dr. Longhurst was saying, we're also going to have to do a lot to educate our healthcare staff about how it works so that they are more able to trust and be confident that what they're getting is based on a good prediction.
Thank you. Dr. Rick, how does this factor into the kinds of interventions that you are developing in the group of individuals you're striving to assist?
Yeah, I mean, I definitely agree with the prior comments. Really thinking about, education, transparency, and all of that as much as possible. We actually don't use generative AI at the moment with our work because for us it's really important because we're delivering a very specific intervention. It's very important that we're delivering the contents that the clinicians have designed in the way that they've wanted that. We are using AI, so we are changing the ways in which Carmen provides its feedback to people in order to best tailor to them. But I would say that it's helpful to be cognizant of the ways in which that this is provided and to be mindful of not overwhelming people with information, since some people don't want to know all of the details of how something is working. And so kind of I think what Dr. Nebeker was talking about is sort of matching literacy levels. I think is also really really key there, and allowing people the option to be as involved or not involved as they want in how the system is actually working and being developed.
Fabulous. Thank you. There's an interesting question in the chat about how AI relates to liability if its advice is wrong. So what happens if an algorithm generates the wrong advice? Dr. Longhurst, maybe you want to start us off again.
Sure. This is a really interesting area, getting a lot of active discussion, in Congress and elsewhere. And the short answer to this is that in the practice of medicine, the clinicians who are licensed to practice are ultimately accountable. And so this case law has been well established for non-AI based decision support that, if the computer pops up with a dosing recommendation, whether or not I take that, recommendation, it's really on me as the licensed provider, right? That I'm accountable. What I think is interesting is that with AI, we're going to be generating evidence that using AI may actually be the best way to provide care. So for example, I talked about the sepsis work at UC San Diego that's led to a 20% reduction in mortality in our emergency department. And certainly nobody would want to turn that off, right? And so at some point, we'll have enough evidence around different types of AI in different situations that it may actually become the new standard of care, which is what we are held to. And so I see a future where health systems and health delivery organizations may actually want to implement AI because it's considered the standard of care, and not having that AI support would actually lead to more liability than having it. But it's going to be an evolution over the next 3 to 5 years as we see evidence emerge around AI in the standard of care.
That's great. Would anyone like to add to that?
I would. I think about,
Yeah.
like, I was teaching a group of postdocs yesterday about the use of large language models as a research tool. When does it support you, and when could you get into trouble? And, some of them are talking about how they're using it to help craft the letters that they're sending for their prospective employment, and how it's been useful in shaping very direct communications. If you're a subject matter expert and you seek information, you can pretty quickly see when the references are incorrect. You can quickly identify when the source of the information is just not nuanced enough to get it right. But you really have to be a subject matter expert to detect the inaccuracies. So you just can't risk that in healthcare and, in the delivery of clinical services. And so, there's testing that's been done to ensure that some models are working very well for certain populations. And then there's those that could still be making mistakes, and you have to have a process in place where you can detect those that are very accurate and trustworthy versus those that still need to have a lot of hand-holding. So and the other piece of this is Dr. Longhurst mentioned about being licensed. And so the healthcare system has so many infrastructure supports in place and a history of an oath, a Hippocratic oath, licensing, oversight, regulations. And now you think about all of these different programs, products that are being pushed out to the mainstream to provide mental health services, to provide just different kinds of support that don't have any of those requirements or obligations. And I think in this case, we really have to educate the public about the differences between sectors and who's in the ecosystem and who is offering health support services.
So let's see, there is an interesting question also from the audience about applications of this to predict AI to predict adverse drug interactions or other events. So do we have anything going on in that area that this group is aware of?
Yeah, I mean, for the work in the surgery field, specifically with the robotics, that new Gen 5 robot. I was talking with my brother yesterday. I think he's the first guy in the world to try this type of special colectomy that's done through their new Gen 5 robot. And when he was training on the robot, he was telling me that he was purposely trying to make wrong moves in the training session to see what it would do. And the AI and the predictive haptics would actually steer you away from it and actually alert you like, hey, that's a solid organ, or hey, that's a critical vascular structure. So he thought that this has incredible application for reducing intraoperative complications because, if you're training residents or fellows or medical students and, it predicts them for making, or a new surgeon who's just, fresh out, their first couple cases in. So for him, he loved when he was doing the case for the first time on a real person, the sense he's like, I can feel the tissue with my robotic fingers, like my fingers are in their body. And it's the haptics are even better than before. So he thinks it's really going to improve the complication reduction rate, especially in surgeons who are just starting out or even older surgeons who are trying to get into robotics, but who don't necessarily have the skills just yet.
Wonderful. Dr. Longhurst.
Yeah, this is a great question. Thank you to the person who asked it. I think there's great opportunity here around not just adverse drug interactions, but also drug dosing and things like this. We've been trying to do this for years in our electronic health records with more manual Boolean-based logic, and it's really hard. We have databases about drug-drug interactions, and they're enormous. And we've learned that firing all those drug-drug interaction alerts to our clinicians just results in people ignoring them because they become nuisance alerts. And so I'm very optimistic that AI is going to help us sort the wheat from the chaff and figure out which are the high priority and most relevant drug-drug interaction alerts to present. Similarly, we're partnered with our SCAG School of Pharmacy around a machine learning project to help us better dose tacrolimus, a Prograf for transplant patients, which is something that's notoriously difficult. And we've already shown in our early models that we can improve that substantially. Of course, the meaningful part is putting it into practice in the workflow, implementing it carefully, safely, respectfully, trustfully, so that it improves outcomes, gets patients to more therapeutic doses more quickly, and shortens length of stay.
Excellent. Thank you. So there's a really interesting question in the Q&A that I'm going to reframe, slightly so that it can apply really to all of our panelists today. And this is about how do we ensure equity and access to all of these new tools that are coming online so that it's not only restricted to healthcare systems and practices that have a lot of resources at their hand.
I can speak to part of that. As part of the NIH Bridge to AI program, a really big component is educating the workforce and educating a diverse workforce. And so they're really paying attention to making sure that there is a really cross-cutting workforce in the pipeline. And the other aspect of this is how to build a data repository that is inclusive of people from diverse backgrounds. And that's one of the data generation projects that's focused on diabetes, type 2 diabetes. But it's also one that requires a lot of really close ethical consideration, because the priority is to enroll people of color and people who in the past have been harmed in research and health and experience more health disparities than the general population. And so there's building representative databases, there's building the workforce, and then there's making sure that there's the compute power that is accessible and available to people that are not at major universities with money for these types of resources. And so there's just a need for everyone to be really thoughtful about the infrastructure that is necessary and who that may prevent from being involved in even the modeling piece of it.
I was just going to concur with Dr. Neberger's comments. In disability studies, there's a really great phrase, which is nihil de nobis sin nobis, which means nothing about us without us. And this means it's really important to fully include and center people historically excluded from the creation of technology, and in particular disabled people and other identities as well, like that might be affecting them, right? And so when in my lab, when we build new robots for healthcare, or we're trying to build a new technology delivered health intervention, we really make sure that the problems we're addressing meet the true needs of the population and that they're included across the entire development process. And this means being very people-centric rather than being technology-centric. And as I mentioned during the talk, like we've built a lot of these partnerships with a lot of community members over the years, looking at how to design and create and deploy assistive technology. Really, these are populations that are just historically underserved. They have under incredible stress. The care partners, as well as like the individuals, are experiencing really negative health outcomes, and this has been exacerbated by the pandemic, right? And so how do we do this, right? Like we spend a lot of time listening rather than coming in with like this is our robot. We try to understand where are they struggling, where are some of the challenges that they're facing in like how they're accessing care, or the ways in which they're managing things, and what are some ways that we can alleviate different types of challenges, right? And so how can we collaborate closely to co-design technologies? I think one thing is, we don't think of people as patients or participants. We think of them as research partners. And I think reframing that can also be very helpful as well. And I think the other thing too is we think a lot about ownership. We want disabled people and their families to be the ones that are creating and shaping and owning the technology, not us, right? And so we're researchers, we're educators, we're not trying to run a for-profit business, right? We're trying to act as facilitators and as connectors and helping people to access some of these tools, right? And so, and as I said, like technology is not going to solve everything, right? And anyone who promises anything, you should be very skeptical of. But if it's designed well, and if it's very person-centered, community-centered, value-centered, it has a lot of potential to do a lot of good.
Thank you. Dr. Longhurst.
Well, I will just pile on and agree with Dr. Nebeker and Dr. Reek, and maybe share 3 examples of how we think about this from a health delivery standpoint. The first would be very general. It's our websites and making them accessible, which today is a very manual process. And of course, we want all of our websites accessible, but we don't always have all the manpower to make that happen, manually. And so AI is helping us to do that in a more automated fashion. It's a great example of using AI for good. The second, maybe a bit more specific, would be things like translation of patient education materials. Again, historically, this has been pretty manual, and even some of the tools that do automated translations just weren't good enough for medical use. We're finding these new AI tools that are just a level better and helping us. So we're carefully trialing some things in the interpretation space. And then thirdly, I want to say it's kind of like politics. Like it's all about the local context. So I shared the sepsis outcomes. One of the things I didn't mention in the talk is we actually found the most benefit in that sepsis AI in our our hospital location that serves more historically underserved patients. And you could ask, well, why is that? And part of the reason is that we trained, our sepsis algorithm using our local data. And so it's helping us to really address some of our existing kind of equity opportunities. And that AI governance, which oversees our local work, includes health equity outcomes researchers and others who are taking that perspective both on which AI alerts we're introducing, how we're monitoring outcomes, and what we're prioritizing from a resource standpoint.
Great, thank you. Dr. Schultzel.
Yeah, I agree completely. I think really when it comes to access, though, there's a lot of cost involved in all these things, right? So, using AI in your clinic doesn't come free, unfortunately. So the big issue, I think, is access. And one thing that we've done in private practice is, for instance, I track my metrics. And so I can go to an insurance company and say, hey, look, here's the length of stay for my surgeries. Here's my success rates. Here's what the community is. And this is why it's better. You should increase the rates of reimbursement. You can actually do the same thing with this and AI. If the insurance companies are made responsible to come on board because this is going to improve the patient care and actually have them be responsible for covering the cost of this, I think this allows it to reach your community clinics where you may deal with underserved populations to your most concierge style practice. Everybody can have access to it because it's really for the benefit of the patient. And it behooves the insurance companies to get on board with this because then they're seeing that their patients are going to be having better health, which reduces their liability and risk and cost at the end of the day.
Excellent, thank you. There's one about whether we think AI would ever become so powerful that insurance companies would mandate their use to help improve the quality of outcomes, and I guess to reduce the costs ultimately would be the goal. Any speculation there from the audience or from the speakers?
Well, first of all, I gotta say, I worry anytime we talk about insurance companies and AI. We've already seen an uptick in denial of claims, and we know that many of our payers are using AI to process this. In fact, yesterday I was on a DC panel with a representative from the insurance industry, and she spoke about putting together a set of principles where AI could be used to authorize claims, but not to deny them. And we would very much support that. Secondly, the payers, particularly our largest payer, which is Medicare, can certainly put in place incentives for using or not using things. And we've seen this in all sorts of aspects of healthcare. So back to my prior comments about as we generate more evidence where AI can actually help us improve the quality of care, it may be from a legal standpoint that it becomes a new standard of care and everybody wants to adopt it because that's the standard we should be delivering. It may also be that payers and others are incentivizing that use so that we can provide the highest value, highest quality, lowest cost care, across the country. So I do think we'll see a point where that happens. But prior to that, we're going to have a lot of evidence generated. And that's a really important point because in healthcare, we tend to be slower adopters not because we're risk averse, but because we want to do no harm. And so we really have to study these things carefully to make sure that we're not introducing unintended consequences when we integrate AI into workflows.
Yeah, as Chris alluded to, Medicare really has made an incentive for if you use an electronic medical record system. In fact, you get penalized if you don't do it now. So really, it's forced a lot of practices to really do that. So older physicians who maybe aren't so computer savvy, they have to pay a fee if they don't use the EMR. There's a potential for that to happen with AI, but there's also an incentive. So part of your incentive with your MIPS scores or some of the other calculations, if you're doing these metrics, you actually get incentivized. So it incentivizes you to go that extra mile for your extra patient care or your higher level of patient care.
So I have a question for Dr. Nebaker. These questions of, as we consider the deployment of AI in medicine and in various other scenarios, questions surrounding ethics and inclusion are often left out. Why is that? And is there a way we could reframe these questions, or do you have any thoughts on this?
Well, just having a lot of experience, I think that the word ethics is somewhat of a trip hazard. And I say that because it gets often intertwined with the regulatory environment. And you can have a practice that meets with regulatory standards, but is not ethical. And one of the priorities for the NIH Bridge to AI was to start and lead with ethical and trustworthy AI and prioritizing people being on the team that could be helpful thinkers in that regard. And working with diverse teams of data scientists, engineers, clinicians, I mean, it's just it's a very bumpy landscape because it's new, and I think being involved with communities is a really critical part, but it takes a lot of time. But it has to be part of that investment. And I say that because they will be excluded if they're not engaged in the process. And an example that I gave in a meeting that I was at just a little bit ago, they were talking about how some of the wearable sensors that they're trying to collect cardiovascular data on were returned. I mean, these are at home, use the tool at home with your baby. They're returned back to the research coordinator, and the research coordinator can absolutely verify they have never been put on that child. And so our experience working here in the San Diego region, especially with very diverse populations, older adults, refugee communities, Latino, Native Hawaiian, Pacific Islander, we find that there are differences in what's acceptable. And in one study that we were going to do to look at physical activity and nutrition practices with people from East African communities that had immigrated to City Heights, they were absolutely confident that they could wear this wrist-worn sensor. They said, yes, absolutely can do this every day for 7 days, and agreed that this could be valuable. It was actually a co-designed study. It was called community-based participatory research, where they are involved as partners to co-design. Well, something broke down in the conversation, because when the researcher went back the week later to collect all of the devices, there was absolutely no data. And so then asking, well, what happened? Where did we disconnect? Well, they said, it's really awkward for us to wear something on our wrist in public. It draws unwanted attention. We have rituals that we go through during the day, and it doesn't really fit with our daily practice. Had you given us something to clip on our belt or our collar, that would have been an easy way for us to participate. But having those conversations up front, learning why there are barriers to participation, and knowing that a lot of some of our diverse communities who have been marginalized over time say yes to get us to stop having conversations. And so we have to build that trust, and we have to build that relationship over time to where they know we're going to actually stick around and maintain the relationship and come back and forth. So Dr. Rick mentioned it before about having these partnerships. That's an absolutely critical pathway. To get that, we have to invest. We have to get our sponsors to give us time, to give us the money. Otherwise, we start leading with a very disrespectful pattern of swooping into communities, asking for letters of support without any authentic engagement, and it creates much more of a divide. So I think investing the time in community advisory boards is going to be, not even boards, but just partnerships, is critical to the success of any of these changes in the healthcare landscape.
Wonderful. Thank you. I'm wondering, when you're Dr. Rick, when you're interacting with community members, do you hear concerns about deploying robotics in home healthcare situations? And if so, what are those and how do you go about addressing them?
Yeah, no, I think in general, people are, I think there's excitement around assistive technology to help people around the home and the community and so on. I think if people see a benefit to a system, particularly if it's really usable and accessible and well contextualized, like what Dr. Nebeker was saying, I think they can see a potential for it to having an impact in their lives. In our work, what we found is that kind of three key concerns: privacy, affordability, and human caregiver displacement. So privacy is huge, of course. People don't want recording devices in their homes, and very few people trust either companies or healthcare systems to keep their data safe and secure, which is very warranted, I think. Affordability is also really key. So, a lot of insurance companies actually won't cover costs to repair or replace a powered wheelchair. So how are they going to support the costs of robots or other technologies, right? Like, this is something that we think a lot about in our work. A lot of others are in the field as well, is, how can we build systems that are affordable to people? And what are ways we can keep our costs low? And that was something that was key in the ways we designed Carmen and a couple of the other robots I showed during my talk, is, really thinking about affordability. And finally, disabled people that we work with are actually quite concerned about human caregiver displacement. And so is it possible that these systems could be putting people out of work? And I think there's some existing work to show that it can, right? And so that's definitely something we don't want. And that they don't want, I should say. So when we build and deploy these technologies, we're really mindful of these. For Carmen, even when we were thinking when we first deployed Carmen, it didn't have a dialogue system, and everyone said, "Why can't I talk to the robot?" Because we didn't want to put microphones in people's homes. And so, but now we're like, okay, this is becoming an accessibility issue. We do need it. People expect it, but it's something we think a lot about, and we're very mindful of.
Oh, wonderful. Thank you. Um, and Dr. Schultzel and Longhurst, I'm wondering if you hear concerns from patients about deploying AI in your practices or from your community in general.
Yeah, I've seen a lot of patients have been really excited about it for the most part. I think the biggest thing with like home healthcare, particularly, is a lot of insurances don't cover it. So if you need some sort of home health support, it's really hard to get it nowadays. So just having that feedback and support, I think initially there's always that, like, is the AI overlord's going to come take over and, and you're not going to have control of yourself anymore. I think that's maybe perhaps a little bit of sci-fi, escaping into reality. So, but in terms of us, within my practice or within my colleagues' practices, we're looking for ways to make what we do better, so we can actually just spend more time with patients and then get home to our families and enjoy our lives. Whereas we're end up being drowning in work with the way that things are going now, and it's actually not really making patient care any better. So we are excited about AI's ability to just as a tool to help us just do what we do better at a higher quality, innovate and enjoy our lives afterwards.
Wonderful. Thank you. Dr. Longhurst, would you like to add anything from your perspective? Are people accepting and enthusiastic by and large?
Yeah, I think so. Dr. Schultzel said it well. Patients, when they're seeking healthcare, are typically not thinking about the tools required to deliver it. They're seeking to feel better or to prevent disease or to have a conversation with their doctor in a humanistic way. And so, as Mark said, I think that these tools give us the opportunity to rehumanize some of what we've taken away with technology. But at the same time, it's still critical that we're doing this in a respectful, trustworthy, and transparent way. I shared the example of the generative AI, and the response we got from our patients was, "I'm really glad my doctor has something to help, because I know they're busy and I feel bad when I message them."
I would like to ask you all to, think about the future of AI and adaptive technologies and healthcare, and what excites you the most. And or if you prefer one of the unanswered questions, feel free to ask one or answer one of the questions from the audience, because the audience did just an amazing job today. So I don't know who would like to go first.
I'll take the ball. So I think my biggest excitement has actually been around the OR optimization. So I really love the work that Qventus has done, just because it has actually changed my life in terms of, like, as a young surgeon into practice, it didn't have block time at the start. The fact that I can actually find a place to put my patients, and then now that I've ramped up and had block time, I can take my patients to surgery now. We live in a world now where we're running out of anesthesiologists. We've had a huge resignation of nurses and other OR techs. So the availability of the operating room is critical. And so now we can actually take care of more patients. My staff love it. It's so much less stressful. So I'm really excited about that. And I think going into one of the questions that someone asked, like, yes, we actually do spend more time with patients. So today, even despite our webinar, I'm seeing about 50 patients today in the clinic. Every patient gets my undivided attention for as long as they want to talk to me. And I don't have to worry much about the documentation, because of the AI has really helped me. And I maybe spend 10 minutes afterwards signing clinic notes, and then I get to go home and enjoy my weekend. But now I spent maybe 3 times the amount of time that I could spend before with my patients now.
Great, thank you.
I will go ahead and just share that what we're learning from the research that we're doing on informed consent is that the way that we go about it is just so standardized, and we've gotten away with it for so long. It's very transaction and doesn't result in an informed person. It results in a compliance process. And what we're learning is that people want information in different ways at different times. It depends on a lot of things. And I think we really have to start moving into developing prototypes for informed consent being successful. But that's just if we put all the weight on the patient or the participant. And that's where it is right now. If we can get that consent signed, we're free to collect these data and do, and go about our business. But we also need to put more weight on data stewardship. And I think that that's going to be really key. Like those that aren't licensed, those that don't take an oath, those that are not heavily regulated are in the playing field. And we need to have really good standards for data stewardship so that we have trust in the system and talk about how we're doing that so that the public feels more confident.
Thank you. Dr. Rick.
I want to, kind of just say something that really excited me recently. So I have this amazing undergraduate researcher in my lab who's been with me since their first year at UCSD, So-Yeon Kim. And So-Yeon's been doing a lot of our really great community-centered work with people with dementia and people with MCI. And, So-Yeon is really excited about gaming and is like a huge gamer. And, last year they said, I really want to do a project with games and I want to somehow do something with Carmen. I don't really know yet. And so he said, okay, let's do some exploratory work. And so, and they said, I really just want to, talk to people. I want to understand their context and their lives. And so So-Yeon designed a exploratory study and sort of went in to talk to people and not really talking about technology at all, right? It was really just a first meeting. They talked about people's hobbies and interests and things they really loved. And maybe they talked a little bit about some of their memory concerns, but not too much, right? Like more like the social contextual aspects of MCI versus something that was specifically clinical or something that was specifically technology focused. And it was just like a first meeting and talking. What was so great about this is like literally the next day, So-Yeon got a phone call from this person. It's like, I have so many ideas. Can we get together today? I made some drawings. I want to show them to you. And it was just kind of this wow moment. Like this is how community research is supposed, like community health research, like this is how it's supposed to be, right? Like this is what you want at the end of the day. And like, is this going to be turned into a research paper? Is this going to be rolled into our robots? Like maybe, but right now it's really about like forming these really strong collaborations and connections and relationships. And to me, that's one of the most exciting things that's happened recently that I'm really looking forward to seeing where it's going to go.
Thank you very much. Great answer. Dr. Longhurst.
Thank you for giving me the opportunity to share the last word. I'm actually going to take a couple of really interesting questions from one of our attendees, Elizabeth Frost. One of her questions is, given that so much of the EMR data is in clinician notes, do you think AI will help us with improving clinical research? Currently, we depend on discrete data, which is a huge limitation. And I want to echo that because we actually looked at this within our electronic health record system. And that data that we keep on our patients, so excluding the metadata about who's logging in the system and the billing data and things like that, it turns out over 99% of that data, just size-wise, is text. So she's absolutely right that we've been firing decision support alerts and writing reports and things on about 1% of the data in the electronic health record. And so I see a huge opportunity to better leverage all of this text data now that we have generative AI to help us not only inform clinical research, but ultimately to be able to do things like lift every practitioner so that they're operating at the highest level, that we're giving diagnostic decision support. The number one cause of medical legal lawsuits and settlements is missed and delayed diagnoses. And we want everybody to get the best possible care as if they're seeing the expert clinicians. And so I'll just wrap by saying that, to paraphrase kind of a saying, I think the promise of AI in healthcare is probably overstated in the next 2 or 3 years. But I think the promise of AI in healthcare is understated in the next 10 years. I think this is going to absolutely transform the way that we deliver healthcare across the country. And I actually think this is going to be the biggest revolution in medicine since the introduction of antibiotics. So we need to do it safely and respectfully, but it's an absolutely magical time.
Wow. Well, thank you very much. And I'd like to thank all of our presenters for giving us such an exciting and human-focused view of what's going on in AI and medicine today and where the future will take us. I'm really happy to have this in the hands of individuals such as yourselves and your colleagues, because I know you'll steer us in the right direction.